thank you everyone for joining us. Welcome to our live class today. We're very excited to have you here and looking forward to a great lecture. My name is Anthony and I'll be your host for today. I'm joined on the line by Dr. Zachary, the founder of Body Love Cafe, who will be conducting most of the presentation today. I'll pass it off to her momentarily to kick off the presentation on today's topic, Sibo testing, a deep dive. But before we get started, I'd like to go over a few housekeeping items. I've muted everybody by default. And secondly, if you have any questions during the course of this live class, please submit them in the chat panel. The questions will all come to me as the host, and I'll be conducting a live Q&A with our presenter at the end of the presentation. With that said, I'd like to pass it off to Dr. Zachary to start the presentation. And we'll just wait. I think we just need to, Dr. Zachary, I think you might be muted here still. If you are, give me just a second here. Yep. Thanks everybody for your patience. Just technical difficulty here before we begin.
Perfect, thank you.
It's like we're in, all right, thank you.
All right, so welcome everyone. So happy to have you here. We have a lot to share today, and one of my favorite parts is the live Q&A. So please feel free. You can type your questions in the chat box as we go along, and then we can answer them at the end. Okay, so this is definitely Sibo, a deep dive. And you can see the heading is being bloated because that's how so many patients show up. There are a small percentage of patients with Sibo who aren't experiencing bloating, but the vast majority, that is their #1 complaint. Okay, a little bit of disclaimer here, just that this is an educational experience. Make sure you always do your own research and practice within your scope of practice for your license. And can you give me a thumbs up just if you can see the slides? Is that good? All right, wonderful, thank you. All right, here's the exact order of topics for today, just so you know. I do have a lot to cover, but if you're wondering, oh, you know, when is she gonna talk about the elemental diet? It's coming. Or when are we gonna get into the vagus nerve? It's gonna show up. So there's just a quick little snapshot of what we're gonna do. I'm going to give you a very brief intro about me because I want to get into all of the content. The personal story is that I was certainly a patient first. I was actually quite sick and declared permanently disabled. Sibo was one of the things I experienced among many others, including a primary immunodeficiency disorder that I have to live with. But I went from in bed 22 hours a day, not being able to work, and in the hospital every 3 weeks receiving a treatment in the infusion center with cancer patients that cost over $700,000 a year. And they said I'd have to do that every 3 weeks for the rest of my life. It just was not working for me. I never felt better. And that's how I found functional medicine. And life has just been very different since then, including being able to launch and start Body Love Cafe, which was so successful. We had to move and expand twice within the first year from 100 square feet and 4 walls to 1,400 square feet, 22 walls, and multiple practitioners. So it's been an interesting ride. My experience with Rupa is I love to teach. I always work with other practitioners, and I actually train physicians and nutrition practitioners all around the world. And when COVID came about, I moved my in-person clinic to virtual, and now we have smaller satellite clinics. And because of that change, we used to ship all our own lab kits ourselves, and I had a full-time dedicated staff member who was having to check 10 lab portals all the time. And by the way, I don't work for Rupa. They have no idea I was even going to say this, but That's when I signed up for Rupa. I said something has to be different, because now we're virtual. I was having to do these things. I was going to pull my hair out if I had to do this all the time. So that's how we found Rupa, and it was such a good experience. You know how something's good when your staff says to you, "Don't you dare cancel Rupa Health or I will quit." And that's what my staff said. And so we've used it ever since, and we absolutely love it. So a very unsolicited, honest endorsement I wanted to share. If you have any other questions about me, I'm happy to answer it. Otherwise, I just want to dive into the content. So let's roll. All right, a quick little snapshot and a reminder of the digestive system, which I'm sure you know inside and out. This is something we work to educate our patients about and to understand that it is one log tube, all connected, and yet each environment of that tube is incredibly different. And we can't just isolate one or another. And sometimes we're dealing with a different problem in the stomach versus the small intestines versus the large intestines. And that can always make things more complex, particularly when you're working with Sibo. And Sibo, it's a form of dysbiosis, but it names its location. So when you talk about dysbiosis, the microbiome being out of balance, that could be anywhere, it could be your mouth, could be your large intestines. When you're specifically talking about this overgrowth of bacteria or archaea in the small intestines, that's what Sibo is naming the location. Here's a quick little snapshot of many of the different digestive disorders patients are going to come in with and the things that you're going to experience and see. And we're focusing on Sibo in the small intestines. You can see the highlight there. Candida is also very common. So a yeast overgrowth in about 2/3 of the patients, possibly parasites also, but about 2/3 of the Sibo patients will likely have a yeast overgrowth. You're going to see a lot of acid reflux and heartburn. Some people have a true overproduction of acid, but it's far less common than most would have you think. What is more common is they've actually lost the ability to properly digest their foods. They have low stomach acid. Food is sort of sitting in the stomach too long. It produces its own acids that will rise up and irritate the esophagus. The esophagus doesn't care why acid is being produced. It just doesn't like it. It's damaging, it's uncomfortable and painful. But these patients you'll start to see an overgrowth of H. pylori. So when there's not enough stomach acid or proper ecology and system in the stomach, the H. pylori will start to flourish. And we certainly have plenty of research and clinical data linking an overgrowth of H. pylori with an increased risk for Sibo. So start noticing those connections with your patients and with labs. And then constipation is really a problem with Sibo. Some of your patients are going to have loose stools or diarrhea. We'll talk about that, but a lot will have constipation. And the reason I wanted to highlight it here is because Sibo, one of the main issues behind it is slow motility. And you often see slow motility as a root cause for constipation. That could be a whole class in itself. I love teaching that because constipation is actually much more complex than people think. And I have a very clear system to go through it. But I wanted to highlight it here because if a patient comes in with constipation and we don't resolve it, we're not going to resolve their Sibo either. And some patients come in and they've been constipated for 3 decades and they don't think it's a big deal. So it is important. Okay, IBS, irritable bowel syndrome. Hang on one second. I want to restart my timer here. Okay, good. So irritable bowel syndrome used to be a catch-all diagnosis. Basically, they would get an endoscopy, they'd get a colonoscopy. If there wasn't Crohn's, ulcerative colitis, some other easy or obvious condition that needed medical management, then IBS was the catch-all diagnosis. Now our knowledge has advanced. Dr. Mark Pimentel is Pimentel or Pimentel, depends on how you say it. He's the MD out of Cedars-Sinai in Southern California that has done a lot of this research, particularly around SIBO, but also around IBS and changing the way we look at it. So it's a huge problem. It contributes to a lot of loss of productivity in school and the workforce. 40 to 60 million cases in the US, 1 billion worldwide. But we know now about 11% or 1 in 9 people that get food poisoning are going to get IBS. Our understanding about the physiology is different. One of the tests you can order through Rupa is IBS Sure that will look at the markers and the toxins from the food poisoning can cause damage and actually damage the cells in the gut, in the lower intestine, and create autoimmunity from the vinculin protein. So there's 2 markers that IBS Sure will test, and that can be helpful to know. If they test for that, particularly the autoimmunity part, it plays a role in SIBO. These patients are much more likely to get SIBO, and they're much more likely to not be able to clear SIBO. So some of your more stubborn cases, this might be an avenue you want to go down and order that IBS Sure. You can avoid overdoing protocols and being over aggressive if you understand that this is involved and move into a more management type of care with the patient. Okay, what is SIBO? Probably most people know, but if you're entirely new to it, it stands for small intestine or intestinal bacteria overgrowth. The small intestines is not sterile, but really a lot of bacteria should not be there. That's where we absorb most of our nutrients. It's the longest part of the intestines, about 15 to 22 feet long with variance among individuals, but it's not where food spends the most amount of time. That's the lower bowel. So when we're doing SIBO breath tests, and we'll talk about testing, typically 90 minutes or maybe 120 minutes with particularly slow motility and constipation cases, we expect food or the lactulose or glucose substrate to move through the small intestine. So we'll get into that in more detail. And this bacteria, by the way, it really wreaks havoc on the body. You know, we talk about being bloated, and people who are not sensitive to that, particularly patients' family members, might say, oh, who cares? But, you know, it's like a space occupying lesion. It's taking up space. It's incredibly uncomfortable. It can hugely impact their lifestyle. The more severe cases of patients are at the point where they're eating maybe 5 to 10 foods. They don't leave the house. Really dramatic. And then the secondary sequelae, the consequences of what happens with untreated SIBO can be quite significant. So here's some signs and symptoms. The type of bloating, you know, there's more than one condition that can contribute to bloating. So like Candida, for example, can contribute to bloating. Some clinical tips, this isn't necessarily research driven, but just a clinical tip. If they wake up bloated or the bloating is sort of hit or miss, might be more yeast driven. If they wake up feeling their leanest, because it's not really a weight issue, but the least swollen, their clothes fit well, they feel the most like themselves. And then as they begin to eat and the day goes on and they get more bloated, and the patient might say at the end of the day, oh, I look like I'm 6 months pregnant. That's a more classic SIBO case. Of course, people will be the exception, but when you hear that, you want to be thinking SIBO. And you can see some of the other issues that come up quite a bit for the role that SIBO plays. Here's some of the common causes, and I'm going to actually show you our guideline and protocol for SIBO. Low stomach acid, certain medications, definitely PPIs. Don't forget surgeries, including exploratory surgery, tummy tucks, C-sections, if they have their gallbladder removed. all of these things can form scar tissue, right? That's part of the wound healing. Even endometriosis, maybe they haven't had a surgery for it, but they do have known endometriosis. It can grow outside of the uterus. It can brush up against and impact the bowel or even infiltrate the bowel. And the worst cases go as high as the lungs. So, some of these scars can be quite an issue. Low thyroid, high cortisol, TBIs, anything that contributes to nerve damage or slow motility, constipation, of course, immune issues, food poisoning for sure. When you hear about a history of food poisoning, be thinking potential Sibo, other structural issues, and don't forget the role of stress. Okay, some of the secondary issues that come out, inflammatory and immune issues, some of the real life challenges for the patient. It can greatly impact their relationships and work, sometimes loss of self-esteem, and particularly some of the anxiety around it, like, oh, I'm worried I'm going to eat this and then get a reaction, or be bloated or be uncomfortable. How am I going to go to this wedding or this graduation? And then depression over repeat cases. Even the best treatment modalities for Sibo have a high relapse rate. It is a very high relapse condition. So we'll get into that. All right, I just wanted to give you a few more notes about what is happening and what is really going on. Again, it's in the small intestines. The bacteria, they particularly love carbohydrates and highly fermentable foods, things that easily turn into sugar, glucose in the body. And I describe it to patients like, they went to Vegas and they hit the buffet. And when they're eating and consuming the foods, it actually becomes a competition for nutrients. They release gases. So we label Sibo by the gases that the bacteria or archaea emit. And that's how we measure it. So they emit hydrogen or methane gas. We'll talk a bit about hydrogen sulfide. And then those gases actually, besides just contributing to bloating, they get into the lungs. And that's how we do a breath test, is then we're able to breathe it out. And that's how we can measure it. But very common to have malabsorption issues. And someone can be malnourished and have malabsorption and be 300 pounds overweight. So they're not always underweight. Talked about fatty absorption. Another thing to remember is very commonly these patients will have leaky gut, intestinal hyperpermeability and barrier issues, or Sibo and Candida overgrowth will then initiate and contribute to barrier issues. And these bacteria, depending on which kind they are, they produce different types of toxins. Particularly gram-negative bacteria release LPS, lipopolysaccharides. And when that gets across that gut barrier and into the bloodstream, now we're getting a whole new host of conditions. I will show you one of my favorite labs for measuring that, that you can get through Rupa, is Precision Point, the intestinal barrier, it's advanced intestinal barrier assessment. We call it the AIBA test in my office, AIBA, but it stands for Advanced Intestinal Barrier Assessment. Very good test. And I think I'm going to show you a sample of that today. But when that amount of bacteria starts getting into the bloodstream and those toxins, that's when you start seeing more thyroid issues, autoimmune thyroid conditions, other autoimmune issues, food sensitivity, depression, anxiety, migraine, some of these other issues, and certainly inflammation, fatigue. Okay, understanding the types of Sibo. So our classic understanding is hydrogen dominant or methane dominant. So we'll talk a bit about the difference between those. And that hydrogen tended to be more loose stools and methane tended to be more constipation. We now know that the bacteria that produces methane is more bacteria-like. It's not a true bacteria. It's a single-cell organism called an archaea. And we've learned even more about it in the research over the years. We've learned that these little gremlins here, they can actually feed themselves, and they can migrate themselves from the large intestines to the small intestines. So more understanding of the complexity of this archaea. And Methanobacter breve smithii is the most implicated for the #1 cause behind constipation. Hydrogen, we've learned the bacteria that produces hydrogen sometimes can be asymptomatic in patients. And sometimes it's hydrogen sulfide, a more toxic type of gas that is causing the patients that have Sibo that abdominal pain and discomfort, and is more typical for loose stools, diarrhea, or a mixed type of loose stools and constipation pattern. We learned more about the cause. We now know that food poisoning contributes so much to gut issues that we have 2 terms. We have post-infectious IBS and we have post-infectious Sibo. And we also know now that Sibo, while a condition in itself, really is a sign of something else going on. So Sibo causes all these secondary issues, but Sibo itself is a secondary issue. So we need to go back and find the root cause. Why does this patient have Sibo? Or there will be no resolution. And that's part of why it's such a high relapse rate. It used to be that, just prescribe some antibiotics, and it was like 85% relapse, and take antibiotics for 2 weeks and you're done. That is really insufficient protocol for care now. It's much more involved. These patients, by the way, they need a lot of visits. They need a lot of education. They need a very customized protocol. They need repeat lab testing. You could specialize just in Sibo and have an endlessly busy practice. If you learn how to really work with these patients and manage them, you're going to be very, very busy. And then the new kid on the block is IMO. That's not a universally used term. It's something the researchers at Cedars-Sinai are using, intestinal methanogenic overgrowth, which is referring to that pattern of what's happening with the archaea and the methane dominant Sibo and LIBO, large intestinal bacterial overgrowth, another term for dysbiosis that is just in the large intestine. So we'll see if that term takes on, but when you see IMO, that's what it's referring to. All right, here's some of those distinct developments just sort of spelled out in another way so you can see it listed by gas. There was a paper that came out in summer of 2020, a research paper that talked about how much the small intestines looks dramatically different from the large intestines. That may be something clinically you already know, but research is starting to demonstrate this. There was a definitive Sibo paper published, I think also in January 2020. You can look that up. And then some of the understandings about these gases, just so you know, it takes, when you see a hydrogen overgrowth, it takes 4 hydrogen to make a methane. It takes 5 hydrogen to make hydrogen sulfide. So sometimes that hydrogen amount can look artificially lower when these other gases are high. And then if you make a shift, like methane can be tougher to make a shift in, but it certainly should be a priority. And if you make a shift and you lower methane, that hydrogen can jump up. You didn't do anything wrong. That's a natural sequelae that you will see as you shift that methane, and can focus more on the next step now. All right, let's talk about some testing options. So the testing standard, like the real gold standard, is a small ball aspirate, which is invasive and mostly done just in research, and we don't recommend patients for that. Also, you can miss Sibo, because the bowel is incredibly long, and if you don't hit the right part, you might miss it, because there's nothing that says Sibo has to be through the entire small intestines. And that's part of what gets revealed with the Sibo breath test, is where is it? Is it earlier on? Is it in the middle? Is it later? So the Sibo breath test is really the gold standard for clinical practice. It's non-invasive. And in medical communities, as far as like in the hospital, sometimes they readily use it, sometimes they're not using it. Part of why I think they don't use it as much, it's very insurance driven, but also they don't really understand effective treatment protocols. So then if they're using a test and they retest and it doesn't look better, then they just say, well, let's not use the test. But anyway, the Sibo breath test is still very much the standard. I highly recommend it. It's possible to do some treatment protocols without testing, but I don't recommend it. I think the testing is affordable and something that should be done. I do recommend 3 hours over 2 hours, because Sibo is a condition of slow motility. It's possible to miss things if you only do 2 hours. And I want to see what happens when these substrates get into the large intestines. Now, some practitioners will do lactulose and glucose, which would be the most thorough. I don't do that because of cost to the patient. I typically don't do glucose because glucose is absorbed and used by the body. It's helpful for catching Sibo in the proximal small intestine, so really very high up in the duodenum. Other than that, it gets used by the body, and I don't consider it as effective of a substrate as we get deeper into the test. So lactulose is preferred if you're able to use that for your license, or even if your patient is able to buy it at an over-the-counter pharmacy or something like that, great. But it's much more effective because lactulose is not absorbed by the body at all. So you're really getting an accurate test all the way through the mechanism. Now, some of these other tests I mentioned, like organic acid tests, Cyrex Array 22, GI map, we're going to talk about a few other tests. They're very valuable and helpful and part of overall Sibo care. They are not by themselves considered diagnostic for Sibo, but they certainly can suggest it. You'll see certain patterns on each of them that if that was the only test you had, you'd be thinking, this patient, it's very likely they have Sibo. I want to order a Sibo breath test now. All right, a couple testing examples. So here's one. This is Genova's test, which we get through Rupa. And the methane is quite high. So you can see they hit a peak of 81. It's considered positive if it's over 10. So at any point in the test, if the methane gets over 10, that's a positive Sibo test. This is the North American breath testing standards and guidelines, was decided in 2017. The lab's going to give you a yellow if that methane is between 3 to 9 parts per million, because again, this is a lot of our Sibo research. It's very likely that there's still too much bacteria there, particularly if it matches up with symptoms. So that's a clinical decision that you would make. But a lot of the researchers would actually do protocols for Sibo if it was 3 or above. Here's another example. Methane dominant, marked as positive, but you can see it doesn't really peak until the large intestines. So this could be an example of a methane bloom in the lower intestines, or IMO, that intestinal methanogenic overgrowth, if you're using the new terminology. Still a problem that needs to be addressed. The patient very likely has constipation, and we know those critters can get up into the small intestine. So even if it's not overgrown at this point, you want to address it and head that off. Here's an example of a hydrogen and methane dominant. You can see by the 90-minute mark that S5, the hydrogen was more than 20 parts per million over baseline. So it's a different way that you read the hydrogen. Their baseline was 5. They hit 40 at that S5. So their score is 35. They had a jump of 35 parts per million over baseline. If it's 20 or more, it's considered positive. Okay, a few testing things to consider as a practitioner. It's more than just positive or negative. There's a science and an art to reading these tests. So don't just go by the labs, positive or negative. Finesse it. Look at where you see highs and lows on that test and correlate that to the body. If that patient has high motility or low motility, loose stools or constipation, and what their symptoms are. So we always have to look at them as a whole. The Sibo diet, the typical Sibo diet is low Fodmap. It does not resolve Sibo. It is not a treatment for Sibo, and a lot of people act as if it is. It really helps manage symptoms. It's helpful to identify if the high FODMAP foods are contributing to bloating. And it's something ideally you want to do short term anyway, 6 weeks to 3 months max. So ideally, we don't want people living on a low FODMAP diet. We don't want to starve the beneficial bacteria in the large intestines. And if they have a hydrogen sulfide overgrowth, the diet is actually quite different. It's more of a vegan low sulfur diet. Again, short term, but that's the more appropriate diet if dealing with that type of gas. If you're new to Fodmap, it's an acronym for different types of fermentable sugars and sugar alcohols in the small intestine. So this is from monashfodmap.com, Monash University, and they actually have an app that can be downloaded to help identify high FODMAP foods. Here's a list of some of those foods. You can get this graphic right off their website. If you want to go to our website, we have our own version. So this is our Body Love Cafe version. And we do this because we do get incredibly complex cases. And so we wanted a highly sensitive column and a sensitive column for where to start those patients that are really tough cases, and then to move across into yellow and begin testing foods and hopefully ultimately get into the orange and not have food restrictions. So it just depends. I'll share a little secret with you too. This was some newer research, is when working with methane, definitely tougher to get rid of, they found that substances that block the enzyme to produce cholesterol, similar to using a statin medication, helped block the enzyme to produce the methane or to allow it to replicate. So that's something that could be utilized and tested in your clinical practice. I don't really like, turning off cholesterol production as a whole because it has so much value in the body. But for those practicing natural medicine, using red yeast rice can also be effective. So you might want to experiment with that a bit. And do test liver enzymes if you're using red yeast rice or a statin. And you can order liver enzymes, get a panel, AST, ALT, GGT, LDH, very easy through Rupa. We do it through Boston Heart through Rupa. This just shows you a little bit more of that food guide. So it's about 4 or 5 pages, and that's the one we use. Okay, let's talk a little bit about Sibo Care. And this is the way we divide it up. So patient comes in, they're bloated, miserable. We're going to do pre and post testing with them. And number one, we need to resolve digestive issues. So they need to have a good digestive mechanism as far as lifestyle practices and what's going on in their stomach, and just sort of that movement from a north to south with the food. We're going to use meal spacing, ideally 4 to 5 hours between a meal so they can complete digestion. This is very, very important because of the MMC wave. So we'll talk a bit more about that. And then addressing structural issues. The next thing is using Sibo Protocols. You have antibiotics. herbal antimicrobials, and the elemental diet, addressing stress, utilizing different techniques, and teaching them about vagal tone and the vagus nerve, and definitely resolving constipation. The next piece is looking at any other slow motility issues, bringing in a prokinetic. We'll talk about a prokinetic, but just about everyone dealing with Sibo is going to need a prokinetic. And by the way, prokinetics are highly effective for your GERD, acid reflux, heartburn patients also. We want to keep things moving. And if they do have fungus, we want to address that. And then lastly, resolve any other issues, that role that hormone plays in gut health, Sibo, and motility. Deal with any large intestinal dysbiosis, leaky gut, and how do we prevent relapse. So that is our Sibo Care that we use in Body Lift Cafe, and what I teach practitioners worldwide for how to work with Sibo. Let's look a little bit more at what's under it. That first piece, some of the things for digestion, I listed a few possible supplements, but just these ingredients, whatever your preference is and your favorite supplement supplier that you feel confident in. A little more information about meal spacing and some of the structural issues. Those of you that do body work or have body workers in your practice or refer out, pelvic floor therapy, breath work, very important to be working on all of these. Okay, migrating motor complex. If you haven't heard that before, the MMC wave. So this is both a mechanical and chemical plus neuro-driven wave that moves food from the stomach to and through the small intestines. And it starts about maybe an hour after eating, can take about 90 minutes or more to complete. And then it's done. It's very important not to interrupt that wave, and patients who are snacking, you put in one bite of nutrition, you stimulate digestion, it turns off that wave, moves into a different phase. So, and then food's left in the small intestines. We don't want that happening, particularly with our Sibo patients. So very important to educate patients about the MMC wave. And prokinetics, which are our next slide, prokinetics stimulate that MMC wave. And there aren't a lot of prokinetics out there. There's some prescription ones, some of the older ones like Cisamide, they had some cardiovascular risk. So the newer one is Motility, which is better, or Prucalopride. And sometimes you have to battle with insurance to cover it. And then some patients don't like it because they complain they get abdominal crampings or loose stools. But often the provider needs to use a lower dose, like 0.5 milligrams before bed is typically how it's taken. And the patient has to not eat several hours before bed. So that can be a bit of a challenge. LDN is a very helpful medication. Low dose naltrexone has many benefits to Sibo patients. It is a prokinetic. I consider it a weaker prokinetic, but there's other reasons why LDN can be helpful. And the natural ones, ginger is a very strong prokinetic agent. So most of the prokinetic supplements will have ginger in it. You want to warn your patients when they take it that they're not having a heart attack. They're going to get like this really warm ginger flush. I describe it if they've ever like drank a glass of red wine too fast. It's sort of a similar feeling. And some patients it's no problem, and others say they hate it. So you might not be able to use a ginger supplementation. I don't have a connection to any of these brands. I will just say Motility Activator has the lowest amount of ginger in it. Modal Pro is a good mid-range. We use it a lot. Prokine has a higher dose, like 5-HTP is the highest in Prokine. I think the ginger is the highest in Modal Pro. So those are a couple, and there's a couple other ones out there. Not a lot of choices. When we have patients use it, in a perfect world, they would take one at the end of each meal and maybe two before bed. Sometimes getting a patient just to do one with dinner is all you can get in. Okay, this second piece of the Sibo Care protocol, I just listed some of the actual Sibo protocols. We're going to go through that in detail, a little bit more about stress and whatnot. Here's the antibiotics options. If they do have methane present, then research shows the best combination is rifaximin, Xifaxan, with metronidazole, Flagyl, or neomycin, either one. So either you're prescribing or you're co-managing with a prescribing doc, but all of these other things with it. So the patient has to sort of get ready for that 14-day period. They're going to eat a higher Fodmap diet just for those 14 days. We're going to get some partially hydrolyzed guar gum in them each day. They're going to take an antifungal, a digestive aid, and a prokinetic. So really sort of a more involved 2-week treatment protocol, and then coming off of it looks different. Lots of coaching. We have some GI docs who will prescribe the antibiotics and then refer them to our office for all this management because they just don't have time for all these pieces. Now, just a little note, rifaximin is the best antibiotic for it. Some patients love it, some hate it. It can be very expensive and insurance doesn't cover it, $1,000 to $3,000, and you don't want your patients paying for that because even with rifaximin, very high relapse rate, likely to have to use it again and again, or likely to have to use other Sibo protocols. If their insurance won't cover it, they can take their prescription and order from some Canadian pharmacies and get it for about $100 to $300. Mark's, Marin Pharmacy, Canada Drug Stop. I'm sure there are others, but those are 2 that we use. Okay, here's some of the herbal antimicrobials that are available. Some of my favorites I listed. If you don't use this brand, just look up the ingredients. I like to rotate antifungals, so I gave you some of the options there and some of my favorites. There's more topicals, by the way, if they're having like a yeasty rash, acne, eczema. Colorex has an intimate wash and an intimate care cream that you can use on different parts of the body, works very well. Grapefruit seed extract works really well. You always need a medium. You can't put it on skin directly. And you do want that to be short-term use, whether you use it topically or orally. Treat it like an antibiotic as far as short-term. I listed some of the prokinetics we use most often. Whenever you're doing gut protocols for a patient, definitely with Sibo, but any type of gut protocol, we always educate patients about it being too easy or being too hard. If they're doing a gut protocol and they feel nothing, it's too easy. It can indicate that some of the bacteria or the yeast is hiding in biofilms. And that's part of how the body's natural defenses and certainly the medication or supplements are not getting at it. So then we need to break down a biofilm. So I listed some of those. If it's too hard, it could be that the protocol is too aggressive. It needs to be stopped or cut in half or given a break. Or it could be that, these bacteria and these yeast, they release different types of toxins, endotoxins, and that's going to irritate the patient. That's part of why they feel crummy, and especially if it's getting in the bloodstream. And when these little suckers die, they're produced also. We used to think it was a Herx response and just some magical thing that patients got worse before they got better. Now we know there's a real biological and physiological process that's happening. And I describe it as a Shakespearean 7-act death scene, that these things just don't go quietly into the night. And depending on the condition of that patient and their sensitivity, and also, how is their liver health? Because the liver needs to detoxify. What's going on with their kidney? Are they peeing? Are they pooping? So all of that needs to be addressed. And they may need a binder. I like Ultra Binder, or if you have a product with zeolites, bentonite clay, charcoal, things that you like. Very short-term use. Prepare them if it has charcoal in it that they can get a dark stool, but that can help bind things up. I listed some probiotics. With Sibo patients, often you don't use probiotics until later, but I listed a few there. Immune support, particularly if you get a GI map test or you're getting a intestinal barrier test or organic acid test, some of these tests that specifically show some immune issues, you might want to give some immune support. You might want to do some leaky gut, intestinal hyperpermeability support. There's the too easy, too hard instructions that I share with patients. And then elemental diet, that's the third protocol for Sibo patients. Elemental diet, definitely short term. It's shown to be 80% effective for 14 days and 85% effective for 21 days. Not too effective longer than that, although I've had some patients where day 23, day 24 was when they felt better. And you don't want to go too long because the elemental diet, just like an antibiotic, you have an increased risk for C. diff. So if you have an elderly patient with loose stools who also has SIBO, I would insist on a GI map to make sure they don't have C. diff toxins or get a C. diff test, because you don't want to use elemental diet or even certain antibiotics if someone is at higher risk of getting C. diff. But the elemental diet, you have to prepare patients for it. What is it like to not eat? It's a liquid diet for, 2 to 3 weeks. What is that like? But it's highly effective. And we use Physicians Elemental dextrose free. You can also do a homemade version. I think that's gross. Most people don't like it, but if needed, you could. Some people worry about the cost of the elemental diet, but they're not paying for food that time. So quite honestly, I think they end up ahead of the game. And all the food is getting absorbed in that proximal intestine, small intestines, in the duodenum. So that's part of why you want to not use it too long, because you don't want to starve the large intestines, but it is effective at starving out SIBO. Some notes about stress and vagal tone, making sure to improve, cranial nerve 10, the function. There's so many different techniques and ways to work with vagal tone. We give our patients a handout, and we may give referral to some of our body workers. Again, addressing slow motility. I've mentioned this a couple times, but I just wanted to list some of the issues behind slow motility and constipation as a whole. It's much more than just fiber and water, right? You have to make sure there's enough fat. There could be hormonal, bacteria, neuronal, structural issues, underlying disease, and the GI map, one of my favorite tests, is excellent for working with that. All right, getting into the last couple sections of our Sibo Care protocol, making sure you address all the motility issues and fungus. So I wanted to give you a couple notes about Candida. Again, that could be a whole separate class, but just some of the signs and symptoms, particularly sugar cravings that are worse at night, recent antibiotic use, things like that, and addressing that at the same time with SIBO. And then the last section of it is addressing hormone issues, addressing lower intestinal dysbiosis, leaky gut, and preventing relapse. So some of the slow motility, hypothyroid and hypercortisol, some of my favorite tests for that, a complete thyroid panel. We use Boston Heart through Rupa, and they'll let you name and pick your own panel, so that's always nice. And then for cortisol, I love the Dutch test. So I gave you a little screenshot of that. So I like the Dutch test because we're going to get all the sex hormones. We're going to get phase 1 and phase 2 metabolism of estrogen. You're going to get a few organic acids, and then you get to see DHEA, you get to see cortisol. You'll see some of the free, daily free cortisol patterns and whatnot. So that's very helpful. And then I just wanted to briefly show you when you're ordering blood labs or your patient brings in thyroid labs, look at it with a conventional and a functional eye. Because, for example, TSH, the most commonly ordered in the medical community, you're not going to get a flag typically unless it's under 0.45 or above 4.5. But patients don't just like jump into a disease state, right? They walk along a path. So someone could be 3.5 and they feel quite awful and they have all the symptoms of hypothyroid and it's ignored. And you as a natural practitioner or a functional medicine practitioner or whatever you're doing can help them. Help them to start to feel better and hopefully walk back towards that optimal range of 1 to 2 and not keep progressing until it gets to a disease state and catches their primary care physician's eye, right? Dysbiosis, just gave you a little bit of information about it. It's a general term for gut bacteria imbalance, but we want to know what's really going on and things we're looking for. And that's part of what I love the GI map for. It's a 5-page report, and this is just a little snapshot of the top of page 3 of that report. But you can see some of the opportunistic bacteria that's overgrown, and some of these are particularly overgrown if someone has poor digestion, SIBO, or constipation. So not diagnostic for SIBO, but certainly give you clues. And then these autoimmune triggers, they're still opportunistic bacteria, but the lab separates it into a separate section because these bacteria are known to initiate and sustain the autoimmune process. So if they're getting across the gut barrier and leaking lipopolysaccharides and things like that, you're more likely to see autoimmune. Okay, I'm going to hustle because we want to get to Q&A here. Some signs and symptoms of leaky gut. I listed a little bit of protocol. You probably know most of this already. This is my favorite test. Again, it's just part of it, but this is that advanced intestinal barrier test you can get through Rupa. There's a lot of leaky gut tests out there, but this is my favorite because I like seeing DAO, histamine, lipopolysaccharides. Zonulin's helpful, but it can be a weak marker. Some people have leaky gut and their zonulin's normal, even though zonulin plays such a role in gut barrier health. So you really want to look at everything else here. And you can also see if someone is histamine intolerant. If their histamine is high and their DAO, diamine oxidase, that's the enzyme that breaks down histamine, is low. Preventing relapse in SIBO is very important. These are my favorite 6 ongoing tips. I share this with patients. And if they even nail number 1 through 3, most of the time they can either resolve SIBO, or if they have some condition, like maybe it's scar tissue or an immune issue, or they're a TBI patient, they have something so they cannot completely eradicate it, right? They're just going to be prone to flare-ups or they have to live with it. You're trying to manage it. Then again, steps 1 to 3 here, if they can really use those, they can live a very normal life. All right, that's a snapshot of the care overall. I gave a few more things like what is the patient experience, bloating, they can have low back pain, food issues. Sometimes they're frustrated, they want a quick fix, and SIBO is not a quick fix. They might be paying out of pocket for all their care, so trying to figure out the way they can get the most for their dollar. Their family might not understand what's going on. The practitioner experience, dealing with patient compliance can be an issue. Sometimes you might feel like you're chasing bacteria, always addressing the root cause. There could be infections, some troubleshooting. When do you order these other tests? When do you retest? Giving referrals as needed, and then making that call. Are they able to have resolution, or are they going to be in a maintenance state? And not being afraid to make that call and educating the patient what it means. I gave a few reasons why the patient wouldn't get better. So if you want to like take a screenshot of that, we give this information to patients also to let them know, these are the things we're working with and managing. There's a lot to dealing with SIBO. And so, the patient, we say, you can't really complain not getting better if we don't address all these, right? If we don't get all of these, resolution is unrealistic. This talks about what's next. If you need some support with me, I do work privately with people and do some group classes through Functional Medicine Academy. If you want support, feel free to reach out. Otherwise, let's dive into Q&A. So what questions, if any, came up for you? And I'd be happy to answer those now.
All right. Thank you so much, Dr. Zachary. What an amazing presentation for today. You really gave some great insights to our viewers on the topic of SIBO. So as you mentioned, let's dive into the live Q&A. We have some questions that have been submitted, and so we have some time to go over these today. The first one we have is, can you go over some of the major tests again to how to evaluate for SIBO?
Okay, so the breath test is the gold standard. That's the one you absolutely want to get, and I recommend retesting. So Genova has a 2 and 3 hour. I recommend the 3 hour. You can choose glucose or lactulose. So if possible, do Genova 3 hour lactulose, and you can do it right through Rupa. If you don't know Rupa, they make it so easy. You can choose to have the patient pay through them or pay you, and then Rupa charges your office, and then they send instructions, they send the lab kit, they let you know when it's ready. And part of why we love it is that SIBO patient might also need a GI map stool test, and they might need the intestinal barrier test, and they might need an organic acid test. And so instead of jumping in, these are all different lab companies. Instead of jumping into all those portals, we just go into Rupa. And plus Rupa lets us know when it's ready. So I always consider them like a free staff member. That's how we talk about them in our office. So, and the breath test, ideally you order it before doing any treatment or protocols, so you know what the baseline is and what you're dealing with. And then after you deliver care, you repeat again. And some docs like doing a SIBO breath test immediately after the elemental diet or antibiotics or using herbs. I actually like to wait 2 weeks. And the reason is because, right afterwards, they're going to look really good, right? It might look like everything's gone and everything was beautiful, but I want to know as they're getting back into real life, do we have lasting progress? So I don't really care if everything looks perfect the day after a protocol ends. I want to know what's happening 2 weeks or 3 weeks later. So I know, are we going to have lasting resolution here? Or, what does it look like? Is there something new to go after now? Did we get it 50% better? Those types of things. And then the other tests, when you, if you're doing GI map, one of my favorite tests, a stool test for the patient, the things you want to look for are H. pylori, if that's an overgrowth, that's on the top of page 2. In the normal commensal bacteria, there's a few that can get out of range, also be suggestive of possible SIBO, not diagnostic, but suggestive. And if Akkermansia is high, that could be suggestive of leaky gut. On page 3 at the top, the opportunistic bacteria, many of those bacteria will get overgrown with SIBO, including they test for the methane family. So that's helpful to see. And then on page 4 of that test, one of the best sections is the intestinal health part, and you will get to see their SIG-A, secretory immunoglobulin A. That's the first line of defense. If it's high, then usually whatever the patients have going on page 1, 2, and 3, it's newer, it's more acute. The body's trying to fight it off. If it's low, it can be suggestive that it's been there for a while and the body can't keep up with it. you might need some immune support. So also calprotectin is there. That's the most studied marker for inflammation in the stool worldwide. So some really wonderful markers in that test. So Sibo breath test, diagnostic, essential. GI map, incredibly helpful. Cyrex, you can order through Rupa, has an array 22, which they can consider diagnostic for Sibo. It's not, worldwide considered a standard, but it's a helpful test. And then the Dutch test, one of my favorites for the hormones, is not going to diagnose Sibo, but it's helpful for some of the issues that play a role in Sibo, and then organic acid tests. So these are all different labs, but you can just get them all in one place through Rupa.
Thank you so much for that. What a well detailed response, Dr. Zachary. All right, so we're gonna move on to number 2 question, which kind of goes off your response. Can you go over why you recommend the 2-hour breath test versus the 3-hour breath test?
Yes, so the and 2-hour, by the way, is more commonly used like in a hospital or medical setting. And again, I think it's just an insurance driven issue and maybe a time issue. But with 2 hours, you might miss a few things. So if that's all you have access to, use it. But the 3 hours is going to give you more time. And I want to see that substrate, lactulose, moving not just through the small intestines, but into the large intestines. So that's why I recommend it. There's valuable information there, not just a positive or negative for this lab test and for Sibo, but get an idea of what's happening at different anatomical locations in that patient's body. In a perfect world, the substrate has moved through and out of the small intestines at 90 minutes, but people's anatomy vary, and some have slow motility and constipation or neurological damage or a damaged MMC wave, or a post-infectious IBS, and others might have high motility and be dealing with maybe some loose stools or ulcerative colitis. There's all sorts of variables. So, that's why you have to always, have your clinical hat on and tie it all together for the patient. But whenever possible, the 3-hour provides more information. I think it's very much worth it, and it's what we use in our practice.
Perfect. Thank you. I think we have time for a couple more questions. Next one is practitioners asking about prokinetics and wondering if you think ginger tea is sufficient for maintenance.
Maybe it's pretty mild when you look at what you get from a ginger tea compared to an actual capsule that has a much higher dose of ginger. The other thing with prokinetics is it's not just ginger. They have 5-HTP. They usually have vitamin B6. They often have acetyl L-carnitine. Sometimes they have other digestive herbs in it and other vitamins. So it's a more complex mechanism than just ginger. If it's working for the patient, then great. But, a prokinetic is a really important role in trying to resolve and manage Sibo. So I would say probably Modal Pro and Prokine are the ones we use most often, and LDN quite a bit. If you're not familiar with low dose naltrexone, it's something MDs have been using for 40 years now, almost in a homeopathic way. Naltrexone at 50 to 300 milligrams is used for opiate addiction. But low dose naltrexone, which is done by a compounding pharmacy, if your local Marin Wellness Pharmacy does a good job and participated in some of the LDN research out of Stanford. I've used like 5 around here, so they're my favorites. But a compounding pharmacy will make 1.5 milligrams to 4.5 milligrams. So 4.5 milligrams is sort of the typical dose. And what it does this is why I say it's mostly a homeopathic action, is it blocks the opioid receptors for a few hours. So don't take an opioid during that time, it won't work. But it'll block the opioid receptors for a few hours. And in response, the body will make more opiates, will make more receptors and more sensitive receptors. And what we have learned scientifically over the years is the amount of opiates your body produces is directly related to your neuroimmune health. So it's not just your level of pain during the day. And we used to not even know that there was a neuroimmune health system in the body. So LDN is very helpful for a wide variety of conditions. People use it for Parkinson's and depression, slow motility as a prokinetic, autoimmune conditions, thyroid issues, fibromyalgia, chronic fatigue. So there's two, like LDN Research Trust and ldnscience.org. You can look up some of that information, but that can be helpful.
We'll have one more question, and that is, do you recommend taking probiotics at nighttime before bed?
With Sibo patients, for sure, because of bloating. So whenever we use a probiotic with Sibo patients, and quite honestly, it became sort of a habit just to start it with everyone this way. We have them take it at night before bed so that if they get bloating, it's not like they took it in the morning and they're uncomfortable all day. And then if they don't get bloated, we say take it any time of day, but we always start with nighttime before bed.
That makes sense. Well, all right, everyone, thank you so much for attending the live class today. We've run out of time, but big shout out to Body Love Cafe and Dr. Zachary, who did an amazing job. We all hope you enjoyed this, and we hope to see you on the next one.
Thanks so much. Bye, everyone.